My name is Delan Devakumar. I'm a professor of global child health in UCL. Is this working okay? Thank you very much for joining. This is the start of the Lancet Commission on Racism and Child Health. This is the beginning of our process, and we hope to work over the course of the next year on issues related to racism and child health, and then hopefully to publish our report, plus a number of other outputs in the years following that. I'm based in the Institute for Institute for Global Health in University College London, and I've been working with a group of commissioners from around the world, some of whom are here today. Today's event is going to be split into three parts. We're going to do some presentations, talking a little bit about why we're doing this work, a little bit about the engagement work that we've been doing, and some of the preceding work that led up to this. We then have an online segment from some of our colleagues from overseas. And then finally, we have a panel discussion with two of our commissioners, Jonathan Wells, Aisha Kadir, and our editor, Dr. Pam Daz. As you see on the screens, there's a QR code. So if you have any questions, please send the questions there, and then we'll pick them up at the end in the last section. So, why are we doing this work? Why racism and child health? I stand here today on World Children's Day, a day where we should look at child health, child rights. Every year, 5 million children die under the age of 5. A further 2 million children over the age of 5 and youths die each year. Another 2 million babies are born dead. This happens every year. And just to put that in comparison, COVID-19 pandemic killed approximately the similar number, but children die every single year. And child mortality is a double injustice. These deaths are mostly preventable. These are not accidents. These are young children usually who will die from infectious diseases, for example, from secondary to malnutrition. Children who don't have access to a trained health professional, to antibiotics, to preventative vaccines. These deaths shouldn't happen, but they do happen. The second injustice is that not all children have the same risk of dying. The poorest children, particularly in the poorest parts of the world, are the ones who have much, much higher risk. And poverty, marginalization, exclusion, exposure to violence, environmental hazards, these are all patterned by race, by ethnicity, by skin color, by indigenous status, by caste, by religion. And this happens here in the UK as well. We have exclusionary laws around migration that act as a barrier to the health system. Data from the National Child Mortality Database show that the infant mortality amongst white children is 3.0 per 1,000 live births. Amongst Asian children, it's about double that at 6.2. Amongst black children, it's nearly 3 times at 8.7. This is here in the UK. And we stand here today with the spectre of the conflict and humanitarian crisis in Gaza looming large. Children are the most affected in this conflict. The United Nations has identified and condemned 6 grave violations committed within conflict that deserve particular priority. And 4 of these 6 are reported to be happening now in Gaza. Number 1, the killing of children. As of the 10th of November, 10 days ago when we last had up-to-date statistics, 4,506 Palestinian children were killed. The number would be higher now. Number 3, attacks on healthcare facilities. Number 5, abduction of children. 30 Israeli children have been abducted and are held hostage. And number 6, the denial of humanitarian access. And Gaza is only one such situation. Across the world, over 450 million children are living in conflict. And children are the most affected in this. And I say this as a child who was born and left Sri Lanka just before the civil war started in 1983. And that went on for 26 years. And I worked in Kashmir, in Myanmar, in Sudan, that's seeing increasing violence as well. Current conflicts are happening around the world, in Ukraine, in Yemen, in Syria. The highest mortality from last year was in Tigray, with over 100,000 battle-related deaths. And throughout history, wars have been fought on racist ideologies. One group is othered, targeted, demonized, deemed not worthy of the same rights. These are structural forces at play. These are not about a few bad apples. Racism is about differential pay, attainment, about equality within the workplace, about microaggressions, but it's also about violence and warfare and genocide. And within this, children are ignored. At best ignored, at worst they are directly in harm's way. That's why we're doing this work. This is a quote by James Baldwin. The children are always ours, every single one of them, all over the globe. And I'm beginning to suspect that whoever is incapable of recognizing this may be incapable of morality. So racism is a determinant of health, and children are ignored within that. And if we want to make change, we have to focus on children. That's imperative. They are a huge part of the population, but also in terms of improving health, we have to focus on children. This work began several years ago with the publication in the Lancet of the UCL Commission on Migration and Health. It then led on to the Lancet series that was published just over a year ago. We held the event in December last year, and these are some of the lead people, Ibrahim Abubakar, Sujitha Selvaraja, Jordan Shannon, and our editors Richard Horton and Pam Daz, who's here today. The key messages from that series was that we need wider recognition of racism, xenophobia, discrimination as determinants of health. And that this is a global health issue. The same things happen everywhere. Same consequences on health happen everywhere around the world, in every society. And that these are structural in nature. We tend to focus on the interpersonal acts of violence, but underline that at the structural causes. We took a very broad definition of what racism is, an organized system that affords power and privilege according to an established hierarchy. And we took quite a wide definition, looking globally, looking at issues of caste, of ethnicity, of indigeneity, of migratory status, race, religion, skin color. And in our previous work, as the next presentation, Dr. Lou Graham will talk about in a little more detail, we looked at some of the mechanisms by which this happens across the life course, from birth up to old age. We thought about the biological mechanisms, the psychological, the physiological mechanisms, and then developed this conceptual model, which really focused on the structural issues. We put the person on the outside. We put the person within the communities that they live in, within the spaces that they live in, and these communities can protect against acts of racism, in some cases can increase as well. As we know, the environment that people live in can be very different. This debate has been played out in London in terms of air pollution. Particular groups of children are more affected by air pollution than others. We then focused on the structural causes, thinking about what lies underneath. And here we thought about separation and hierarchy, these ideas of groups of people being separated, but then those groups being organized into hierarchies where certain people are above others. And then the health systems and institutions by which this acts. And finally, we developed 6 key principles. The principles of decolonization, of looking at intersectionality, of focusing on diversity and inclusion, reparative justice, active acts of anti-discrimination, anti-racism, and taking a human rights approach. And so through this work that led up to the current commission, we kind of developed some of the definitions, backgrounds, conceptual models that lead on to the work that we'll talk about today. So the commission, as I mentioned, is starting around now. It began about a month ago. And the main goals of the commission are to advance the field of racism and child health, to make a scientific advancement, to be intervention and outcome focused, and to work with children and adolescents, as has been shown so eloquently throughout the whole day. And then to advocate for children, and ideally to catalyze change. We brought together a group of commissioners from around the world. We have 20 commissioners and 4 members of the steering group. You'll hear from Sonora English and Lou Graham today. The other 2 are Meetha Hawke and Abhi Devanayagam, who couldn't be here. And then we have 20 other commissioners with a wide range of experience and expertise on health and global health, but much more broad on education, on sociology, anthropology, people who work within higher education, people who work in non-governmental organizations. And we've brought all of these people together and started to think about the kinds of work that we do, focusing on the data that exists and the data that is lacking as well, thinking about what kinds of interventions work, why some work in certain situations, why others don't work, trying to take a complex system approach to think about interventions in the whole systems in which they occur. An intervention by itself may be very effective, but once it's put into a wider health system, for example, it may not function. We want to think about some of the upstream causes, the political causes of which children experience racism, and some of the policy consequences from that. And then we want to focus on some of the crises, and these are crises that are likely to affect children in the longer term. What's going to happen in 10 years, in 20 years? We came together a month ago and started this work and started to think about the mechanisms by which all these things may happen and the ways that we may try to improve health for children. And we've been working with children and young people, and that will continue over the course of the year. One of the following presentations will go into more detail on this. And we've also been working with the Children in All Policies group that has a youth advisory board that we're taking advice from as well. And finally, I'm going to show you a short animation, and this has a few of our commissioners and a couple of young people as well. We asked the question, what does racism mean to you? And it's very easy for me to show you conceptual models, talk about structural racism, but racism really is a very personal thing.
El racismo para mí significa definir a otro como distinto y diferente a mí, de una manera tal que vale menos como persona. Por ejemplo, en Chile, donde yo vivo, crecí en una familia donde el tener color de piel blanco, ojos claros o color de cabello claro tenía mayor valía, y yo, siendo morena, sentí desde muy pequeña que yo entonces era menos bonita, o lo que decía o pensaba importaba menos. En el espacio profesional también he sentido experiencias de ser definida como menor valía por ser latina en Europa, lo que hace que uno viva la vida desde un lugar de más miedo, de mayor inseguridad sobre lo que piensa, hace o dice.
Racism to me is the beauty standard that we have in Samoa. If you look more indigenous or local, people will treat you in a way that is less than they would treat a foreigner.
My first awareness of racism was as a young brown child visiting the UK. It was to feel judged or watched every time I went into a shop or boarded a bus. It was to know implicitly that I was considered to be a different category of person than the members of a more powerful majority. It was to feel that I had to be an exemplary representative of my minority group who was deserving of acceptance, and to know that I always had to be alert to my precarious position. When I returned to live in Sri Lanka, my situation was completely reversed. I was privileged to be a member of the majority, and it was my neighbors, friends, and colleagues from minority groups who lived with the very real possibility of violence that could threaten their homes and lives.
I recognize racism in our school systems, but in the form of colonialism. As a Ugandan citizen, we were colonized by the British, which means that we had to adopt the British education system. However, years after we have gotten our independence, we are still, to a larger extent, being taught with the same education structure, which to me feels just not right. To a larger extent, the education that most Africans are getting is still colonized, so it makes it very unrelatable to young people.
Racismo é que é errado a gente falar mal da pessoa só por o jeito que ela é. é muito errado. Então eu ia falar pra professora quem tá fazendo racismo pra ela conversar. E é isso.
So thank you especially to Mitha Hawk, who created that animation. So we're now going to move on to the second presentation. Dr. Lou Graham is going to talk a little bit about the previous work from the series, and then we'll talk about our engagement work.
Hi everybody. It's good to see many people showing up today to this important event. So I'm going to talk a bit about the findings of the Lancet series on racism, xenophobia, discrimination and health, and the evidence on it. So what does the evidence say on racism and health? One of the first things that physicians will tell you is that they care primarily about mortality. That is one of the health outcomes that they put a lot of stock in. So what does the evidence say on that? Well, we can look at COVID-19 as an example. During the early period of the COVID pandemic, there were clear differences in who was more likely to die of COVID. This is data released from the Office of National Statistics, finding that almost every ethnic group was more likely to die of COVID than white British. And in particular, Bangladeshi women and men were 4 to 5 times more likely to die of COVID than white British counterparts. Pakistani women and men were about 2.5 to 3.5 times more likely to die of COVID than their white British counterparts. This is not a coincidence. It didn't just happen to be the case that all of the non-white ethnicities were more likely to die of COVID. We know there are various reasons for this, such as minoritized groups being more likely to be infected with COVID, being more likely to work as key workers in frontline jobs such as healthcare that exposed them to COVID. They were more likely to live in overcrowded accommodation due to poverty, and they were more likely to get serious forms of infection due to various institutional racist barriers to accessing health services. In sum, it's very clear from our experience with COVID, which is also something we've known for a long time, that racism kills and racism is a public health crisis that we can no longer ignore. So we did a systematic review of the literature that was out there on what kind of health outcomes were affected by racism, and there are too many health outcomes to go through in a short presentation like this. The evidence was both overwhelming for the impacts of racism on health and a gross underestimate, because we were only looking at literature where racism was explicitly named. And there's tons of literature out there looking at ethnic differences in health where they do not name discrimination as the cause of these health differences. But we see a huge range of different impacts, from impacts on mothers and babies in utero even before birth, to impacts in childhood and adolescence on children's mental and physical health, even leading to increases in mortality. And also, we have great evidence on the biological mechanisms. It is not a mystery. We know that chronic and repeated exposure to psychosocial stressors can fundamentally alter your bodily responses, even sometimes leading to visible changes in brain structure. But racism doesn't just affect individuals, it also affects systems. Racism is not just bad for individual people, it's bad for society as a whole. We found in our review that racism affects health systems through degraded performance of the health services in the form of either poor availability or accessibility of healthcare for minoritized people, to discrimination experienced by health workers themselves, to poor communication between health workers and patients, and poor quality of healthcare for minoritized people. Ultimately, the causal pathways from racism to poor health affect people at multiple levels and require a multi-level framework to explain. That's how we developed the conceptual model that Delan has talked about. At the core of this model is this issue about structural discrimination. So microaggressions, overt racism are also important, but they're only part of the picture. Separation and hierarchical power, othering of other people, with deep historical roots, such as colonialism and the transatlantic slave trades, leave long-lasting impacts that are felt around the world. At the same time, in the present day, we have institutions and systems, including health, education, economic, political systems, that do patently affect people's health in racist ways, such as the current inhumane system on migration controls, where even though the migrants that arrive in the UK, the so-called boat migrants that arrive in the UK, account for less than 5% of migration into the UK, are still labeled by both politicians and prominent people in the press as some kind of invasion, even though they're risking their lives to cross the Mediterranean. Then we looked at spatial determination that represents the impact of the spatial environment in which we live, including the impact of the climate crisis, the impact of racial segregation, the impact of the fact that minoritized people are more likely to live in proximity to pollutants and toxic wastes, and finally to communities and individuals who are affected by exposure to overt discrimination and stereotyping, as we saw during COVID-19, when East and Southeast Asian people were discriminated and stereotyped as carriers of the virus. But we also found, and this is the third paper in the series, that a single-minded focus on race is not enough. Just like people do not live single-issue lives, so we cannot tackle the issue of racism by focusing only on one single factor. We took a case synthesis approach, looking at cases of intersectionality where racism, gender, class, disability, and other kind of characteristics combine together to produce unique experiences of discrimination in Australia, Brazil, South Africa, Europe, North America, and India. And we also looked at the commonalities in how people experience these different forms of discrimination. In particular, the commonalities were in the terms of how history and coloniality affected the operation of oppression today, how separation and hierarchy across lines of identity and privilege reinforced oppression, how oppression was institutionalized in our systems, our laws, our practices, our health systems, how visibility and invisibility of people, problems, matters, shaped the way in which oppression worked, and how oppression always worked through the use of violence, whether direct, cultural, or structural. But when we looked at what kind of actions had been taken, what kind of interventions had been researched, that's where we were the most disappointed. The evidence was often quite weak, small scale and short term, and extremely focused on racism experienced in US or in wealthy high-income countries. In fact, a systematic review in 2015 found that 81% of studies of racism and health had been carried out only in the US, and at that time, no studies had carried out studies of racism and health in low and middle income countries. But we also found that the little evidence there was showed that racism and its impacts on health, you can do something about it. You can do something at the individual level, looking at changing attitudes of perpetrators, at the community level, looking at increasing empathy, looking at the health systems level, developing cultural sensitivity program, and looking at the institutional and structural level through various wide-ranging government programs. Racism and its health impacts on health is not a fact of life we just have to live with. We can do something about it. So we concluded that action must be multisectoral, society-wide, and truly global. So now I will hand over to Sonora to speak. But before that, I would like to thank the whole team, loads of people involved in this, and I'm just one person standing here. I'm by no means the one who's done most of the work on this, especially Delan, Sujita, Jordan, and Ibrahim, who led the 4 different papers. All right.
Hello, everybody. It is, a little bit shorter than new. Okay. Hello everyone, it is a pleasure to be here with you all today. My name is Sonora English, I'm a research assistant at Race and Health. Today I will be talking to you about how we are centering children in our work. So this Lancet Commission on Racism and Child Health is all about children and about how their health is impacted by racism. As such, children, specifically children who face minoritization due to race, ethnicity, skin color, indigenous status, migratory status, or caste, they need to be at the very center of the work that we're doing. So, we have to take a child-centered approach. Now, what does that mean? For us, when we say child-centered, we mean prioritizing the needs of children and valuing their voices. That means we have to listen to them. This approach is needed because children who are most affected by these inequalities are usually excluded from the knowledge-making processes like Lancet Commissions such as this. And so including their voices is incredibly important to making sure that we combat those types of minoritization. Everyone on this commission, however, is an adult. So in order to include children and take a child-centered approach, we have to listen to their voices and support them to engage with us and take an active approach to engaging with them. So in order to engage with children and ensure that we are taking a child-centered approach that centers their voices, we are doing two main forms of engagement with young people. Firstly, as Delan mentioned, we are working with a youth advisory board. The youth advisory board is the youth advisory board of another research group called Children and All Policies 2030, or CAP 2030, and they work with an international group of young people. We are also doing open engagement with children in Brazil, Uganda, Sri Lanka, and Australia. So the reason that we're doing two separate engagement approaches is because this allows us to ensure that we are both engaging with children throughout the research process of this commission, and also that we are incorporating work that is child-led in the commission as well. So a little bit more on the Youth Advisory Board. As I mentioned, we're working with CAP 2030 and their Youth Advisory Board, which is a group of young people aged between 13 and 18. The Youth Advisory Board will advise us throughout the research process, and will be working with us. We've already started working with them. We started working with them before the commission started, and we'll be working with them throughout the whole process. As suggested by the name, they play an advisory role in our research. So they are going to be informing the approach that we take to the research by advising on the content and progress of our research. We're very committed to making sure that our engagement with these young people is a genuine engagement activity through really taking their voices into account rather than just having a youth advisory board in a tokenistic way. So far, the Youth Advisory Board has helped us develop our priorities for this commission. So we consulted them before we first met as commissioners, and we asked them what they think is most important to research in the area of racism and child health. And they told us what they think, and then we all talked about that, and that's going to inform our priorities for this commission. Some of the things that they have shared is the need to take into consideration inequalities in incarceration and inequalities in access to quality education, the value of rights-based approaches, and also the need for the solutions and interventions that we look at to be time-sensitive so that they can help improve the health of children now rather than only in the future. Moving on to our open engagement work, which we are very excited about. As I mentioned, we're doing this in several different countries. For now, we know that it is going to happen in Brazil, Uganda, Sri Lanka, and Australia. In contrast to our work with Youth Advisory Board, this is an open-ended form of engagement because we have kept the nature of it and what we're going to be doing with it open so that we can co-develop it with children. This is really important to us to ensure that there is a co-produced form of engagement that is really led by what children want and what children are prioritizing in this space. Overall, our aim for this area of work is to provide children a safe and supportive and empowering space to talk about and explore racism and health together. And our colleagues in Brazil, Sri Lanka, and Uganda all have experience working with children in these ways already. They've collaborated on a project, including with Race and Health, called Envisioning Environmental Equity, where they've created outputs with creative outputs with young children or young people about racism, climate change, and health, creating films and comic books. And so as a result, we hope that this engagement process will also be through creative methods, which we found are a great way to engage children around these difficult topics. We also plan to include these creative outputs as a component of our commission to ensure that children's voices are genuinely integrated. So we're not just doing this for the fun of it, and like I said, we don't want it to be tokenistic. We're doing it also because youth engagement is very important and it has lots of benefits. So youth engagement can transform power dynamics within research. It can democratize knowledge, and it can reverse the unequal power imbalances between children and adults. There are also direct benefits to the Commission, to our research, because children are experts in their own experiences and in their own lives. And so to be able to learn about them truly and to be able to conduct research about their health, we need to learn from the experts, to get it from the source, I think, as someone said earlier today. There are also benefits to children, which is very important and very important component of this. Primarily, youth participation can empower and increase confidence through children being heard and respected. And we think that's especially important for the minoritised children that we are working with and hoping to improve the health of through this commission. Thank you very much. We now have a video which I will hand over to Delan for.
So most of our commissioners are not based in the UK. So to try and get some of their views included, we made a short film with, I think, 5 of our commissioners, asking them, what does racism look like in your context?
In her report to the United Nations General Assembly, the UN Special Rapporteur on the Right to Health proclaimed, the right to health cannot be realized in a racist world. Through this statement, what the rapporteur was doing was reminding us all of the biases and abuses faced by minoritized people across the globe. The predominant concept of global health evolved as a humanitarian rescue mission to the global south by philanthropists, charitable organizations, and public health experts from global north. Indigenous people, as well as people of African descent, Roma, and other ethnic minorities experience stigma, racism, and racial discrimination. This situation, according to WHO, often increases their exposure and vulnerability to risk factors and reduces their access to quality health services.
To me, racism has to do with historical colonialism, structural inequalities, and the way we see each other and the otherhood. Therefore, the opportunity to improving the well-being and health of children and adolescents in our region and in the world has to do with recognizing and preventing racism to every person, especially children.
Racism meant that children such as me were not fortunate to be born white. From the time they took their first breath, their potential was already limited. Apartheid as a formal policy was abolished almost 30 years ago, but we live with its legacy to this day. Children from formerly discriminated groups are not able to live life to the full in terms of their health and well-being, whether these are defined in narrow or broad terms.
Racism is the ideology, it is the belief system that supports the ongoing coloniality that we experience here in New Zealand, but that which many Indigenous peoples are experiencing around the world. Racism operates to sever the ties to sever the relationships that are created around a child and a young person and that are critical for them to be healthy and well. And those relationships exist at multiple levels. So when we see information that talks about Indigenous children being uplifted or removed from their families and put into state care, we have to remember the important relationships that are being severed between a child and their family, which all of the information and literature tells us is critical for lifelong well-being.
I'd say that racism in child it's one of the strong drivers of inequalities, because it not only puts you in a differential position to achieve the same than others, but also it makes your life much difficult and harder. Let alone child health outcomes. We know that First Nations people have worse health profiles than non-health people. Unfortunately, this data is not systematically collected.
I remember walking on the beachfront with my daughter and realizing that we're walking on sands that a couple of decades ago were not allowed to tread. You see, I was born in South Africa, a country in which it was illegal not to be racist. Nowadays, people talk about apartheid in different contexts, but it was here in South Africa where this racist system was created and perfected. The discriminatory policies it informed determined the sort of education, health, and other services people were allowed to access based on their race. The beach on which I was walking would have had a sign that read, "Net blancos," or whites only.
As the 2022 Lancet series on racism, xenophobia, and discrimination pointed out, COVID-19 uncovered social and political fractures within communities with racialized and discriminatory responses to fear disproportionately affecting marginalized groups. Political leaders have misappropriated the COVID-19 crisis to reinforce racial discrimination, doubling down, for example, on border policies and conflating public health interventions with anti-migrant rhetoric. Many of these realities, these patterns of discrimination and bigotry, were always there. What COVID did was expose them and laid them bare for everybody to see.
We also have to remember that those state institutions are themselves places of harm and places of ill health for Indigenous children and young people. And so that is an important element of how racism impacts child and youth well-being. Similarly, when we see media reports or academic articles that talk about the hyper-incarceration of Indigenous women in prisons, then we have to remember the evidence that tells us how critical the mother-child relationship is for child health now, but also for lifelong health and well-being. I see those impacts as a breach of a child's right to health, but also as a breach of an Indigenous children's right to be free from discrimination and to live freely as Indigenous peoples on our own land.
I was born in Peru, and Peru has had hundreds of years of colonization, and people have different ancestry, different languages, yet the perceived value of people across the entire country is not the same. For example, teaching people and teaching the entire nation in Spanish, whereas for some and for many people not living in cities and not living in urban areas, that's not their native language. So you grow in that environment where you are trained, or you go through an education system that doesn't recognize your language. You grow in an environment with less opportunities. Socially, you receive less chances as well, and working in your productive environment that you have less options as well. So in summary, the experience of racism is sort of this intergenerational, but also long-term across the lifespan, long-term sort of chip that goes into your brain that you're different and actually that you're inferior. And that's growing with that burden. I wouldn't wish that for anybody.
tide against apartheid turned when the world stopped propping it up directly and indirectly, and its continued existence became an unsustainable burden to its architects and proponents. It is thus my hope that this commission will contribute to creating an environment in which it is not possible for the world to ignore the harm and damage that racism and discrimination does to people's well-being, in particular to the health of developing children, taking away their potential even before they knew they had it. It is my hope that the Commission will catalyze the emergence of such an environment that gives people the courage to see, but even more importantly, the courage to respond appropriately to creating a world in which each child is allowed to thrive, irrespective of the color of their skin.
So I'm hoping that this Lancet Commission on Racism and Child Health helps us all to remember how racism supports a range of different oppressive systems that limit the lives and cause harm to the health and well-being of children and young people across the globe. And finally, I think about the way that racism operates to sever the ties that Indigenous children and young people have to our own knowledge systems, be they scholarly knowledge systems, language knowledge systems, cultural practices, and other systems that have for centuries supported and nourished all Indigenous peoples to be well. And so again, I think this is a really important opportunity for the Lancet Commission on Racism and Health for children and young people to really help lift our gaze, not just on the ways in which racism causes harm to children in terms of physical and mental health, and they are really important issues for us to consider, but also the other types of harms that are created in relation to social cohesion, in relation to familial and community relationships, but also in relation to the rights of Indigenous children to access and practice and celebrate the knowledge and the languages and the ways of knowing and being that are unique to us and part of our holistic way of thinking about health. I think that rights-based social justice perspective is something that the Lancet Commission on Racism and Child Health can bring to our existing scholarship, and that we can use to advocate for states to uphold and remember their responsibilities to ensure that all children and young people's rights are being upheld, and that all children and young people are supported to live full and healthy and flourishing lives.
What I wish from the Commission is to make visible these differentials. I think we, from the health sector, we are very much used to see differential in groups, but the pressure and the enormous, substantial negative influence of racism during childhood is devastating. So in a way, it affects our human capital, it affects our productivity, it affects everything that we strive in society. It is morally wrong. And what I expect from this commission is to bring that voice loud, front and center, and also shake paradigms, shake people that those views are unacceptable in the world that we live today, particularly thinking on a planet with a sustainable future. What I would also like to see in this commission is bring closer the voice of the youth to tell us, because they have to live through in the future through that, and to why not imagine a different world with a different future.
The question that we need to be asking in 2023, why is this still not happening, and why these issues continue to mar the global health agenda? In a statement on the impact of racism on child and adolescent health, the American Academy of Pediatrics in 2019 noted that racism is a driver of health inequities, and that the failure to address racism will continue to undermine health equity for children, adolescent, emerging adults, and their families. Strategies to address health and development issues across pediatric lifespan that incorporates ethnicity, culture, and circumstances are critical to achieving a reduction in health disparities. The paternalistic origin of global health has fostered power structure and culture of supremacy that considers prior consultations with the beneficiaries unnecessary before decisions are made on the health interventions to offer, pointing to the imperative of involving Black people living in Africa in setting the priorities for global health research. Repeat calls are made to recognize racism and xenophobia as fundamental determinants of health and to implement measures that focus on addressing the structural causes, however, with limited success. Time is now to take transformative action to address racism in global health. Thank you.
Move on to the last segment of this session, which is a panel discussion. So I'd like to invite three guests, Aisha, Jonathan, and Pam, to, if you have any questions, there's a QR code there. If you could put them in. We're going to start with a few brief introduction, then a few questions to the panel here, and then we'll go around to all of your questions. So let me introduce three guests. So the far end, Professor Jonathan Wells, who's a professor of anthropology and pediatric nutrition at UCL Institute for Global Health. Sorry, Institute for Child Health. I keep on getting that wrong. We're in the same building. Jonathan completed a degree in social anthropology, an MPhil in biological anthropology, and a PhD in biological anthropology and nutrition, all at the University of Cambridge. He then moved from there to UCL, and his work embraces birth cohort studies, randomized trials of nutritional and stress reduction interventions for mothers and children in low and middle income countries to improve nutritional and metabolic health for the long term. We then have Dr. Aisha Kadir, who is a senior humanitarian health advisor at Save the Children. Aisha is a pediatrician, and she works in clinical care, public health research, health policy and advocacy. Her work is in pediatric emergency medicine and social pediatrics in Europe, and in humanitarian settings. Her research, advocacy and policy work focuses on the effects of migration, armed conflict, and the intersections of different forms of violence on children and families, and in finding effective ways to protect and promote children and families' health, well-being and rights. And finally, we have Dr. Pam Das, who's a senior executive editor at The Lancet. Pam joined The Lancet family of journals in 2001 and co-leads the journal's global health work and oversees The Lancet's comment and news sections. Pam was a co-founder and is a current member of The Lancet's racial equality group, GRACE, and an advisory board member of the Global Health Film Festival. So I'm going to start with a broad question to all of you about how racism and child health exists in the worlds that you work in. To Aisha first, in the humanitarian world. I talked a little bit about this before, but could you elaborate on this, please?
Does it work? Yeah. Good evening, everyone. Yes, I mean, I think the biggest, sort of for me at least, the most apparent situation that we have, if you kind of zoom out and you look at crises worldwide, there's quite a striking distribution of where crises occur. And there's also a rather interesting distribution of which crises receive attention, which groups within crises receive attention, also which groups, what kind of humanitarian response is organized and who is the target for that response. And now we're also starting to see who gets sustained attention for responses. So there's a very clear racial distribution, and there's also geographic distribution, and that is kind of a apparent, basically a large scale or macro scale picture of whose lives are valued and whose are not. And then when you look within that and you specifically look at children, there's another layer. And we're talking about racism, not age discrimination, but the data on the visibility of children in data, particularly in crisis context, is very limited. And the way crisis response is mounted, there are different sectors we've organized ourselves into, and there are some that specifically focus on children, like nutrition. They focus on, so there's a sector separate to health, which as a pediatrician I still can't wrap my head around, but there's health and then there's nutrition. And nutrition is focused on children and women. Health is focused on the whole population, and within that is very much focused on adults. Children are there. They account for easily half in most contexts, if not more, of the population that are affected, but they're not the focus of a general humanitarian health response. And so when you look at the geographic distribution and then you look at where children are, you see, again, some really striking patterns of whose lives are valued and whose are not. And the money that follows these responses and the money that shifts around is, again, an indication of that. So I think when we look at crises and we also look at the drivers of crises, climate being a major one as well, again, we start to see these patterns repeat. When we look at migration, again, we start to see these patterns repeat. And migrants, people who move or are forced from their homes, are often multiply marginalized. And so they're more vulnerable to crises, to, for example, effects of climate change. So you kind of see this kind of growing and growing and growing. And I think so this is a really important component of this commission, and I'm very grateful for the opportunity to support it.
Jonathan, we did a podcast recording called Under the Skin where you spoke about how racism leads to poor health. Can you talk a little bit about the kind of biological pathways that this happens?
Okay, good evening, everyone. So we're an animal, and animals have a stress response, which allows an animal to take action if it's threatened. And in the short term, that's a really valuable thing for an animal to have. If you see a predator, you want to allocate all your resources to escaping from that predator. Your heart rate goes up, your blood pressure goes up, and you flood your metabolism with fuel for your muscles. But today we live in societies where we don't suffer from other animals predating us, but we have a lot of threats from other humans. As you've been hearing, the way that societies are unequally structured distribute not only resources unequally, but also threats. Racism presents to the body as a threat. And if you activate the stress response continually, it causes tremendous damage to all sorts of aspects, cellular health, organ health, mental health, and so on. We now know a lot about the mechanisms by which this happens, especially in early life. We can change the expression of our genes. It's not the genes themselves, but the way they're behaving in the body, epigenetic changes. We can change aspects of the cells that govern how long that cell is likely to live, and in that way we can affect the lifespan of people. We can change the composition of the microbiota to be more inflammatory. That might have benefits in some situations, but if you chronically change these aspects of biology, they just continually damage health. And the outcome of all of that is a fast track to chronic non-communicable disease like diabetes and hypertension, poor mental health, and as we heard from Lou, even effects on brain structure. So you think, how could experience get under the skin? It really does get under the skin. And if you think about mothers experiencing stress in pregnancy, that means the unborn fetus is already experiencing racism before it's being born.
Thank you. Pam, to you, what role does the Lancet play in this space?
Well, thanks. First of all, thanks for everyone for coming to this event. I'm super thrilled about this commission. Oh, sorry, I've got a loud voice as well, so it doesn't really matter if I use the mic. To me, it doesn't make a difference. I'm super thrilled about this commission. Many of you may know, but some of you might know, the Lancet is really unique amongst the major medical journals in that its commitment is really centred around improving health, achieving health equity, and advancing social justice. I'd say, particularly in the last 5 years, our attention to racism has been spurred by a number of things. You will all remember the events in 2020 with the killing of George Floyd and others, and it was really a turning point, as you know, in terms of the conversation, and lots of us in organisations and systems and institutions all began to take a very, very hard look at ourselves. And it was a key moment for us at the Lancet to see how we could really contribute more to these anti-racism efforts. We issued a number of very public worded pledges, and in order to kind of keep ourselves committed to those pledges, we thought that we would start looking at our content to see how we can use evidence-based medicine and our thought leadership through Commission's series, as you heard today, of the Advancing Health Equity series that we published last year, and really looking at also our publishing practices, our policies, things such as authorship, improving diversity, improving the representation of low middle income authors. Often on papers you see helicopter research where northern institutions come in and they do their work, and the authorship has all northern authors, and then you'll see a tokenistic African author or Asian author at the end. This isn't the way things should be. This is just perpetuating the old structural systems of colonialism that we've heard a bit about today, and I'm sure that many of you in this audience will know about. So on the back of this special issue we published last year, not only do we have this Commission on Child Health and Racism, but we need to look at different aspects of the racial structural environment. So we have a commission looking at the legal frameworks, the laws and policies that allow some of these very non-progressive, very backward legislation that perpetuates the biases and discrimination that we see against minority people. So we have a Commission on Racism, Structural Discrimination in Health. We have another commission that's very US specific, because US is a very unusual case. Its history defines its colonial path in many ways, and that particular commission is going to be looking at Black people and their interaction with the health system and how the discriminations there across populations, not only Black people but minority people. And I think by looking at racism from these different lenses, what we're doing is building up a body of evidence, because let's face it, policymakers always say, what's the evidence? Where's the data? And we need to provide that data. And we need to look at different forms of data as well. It's not just the big studies, the big RCTs. You can't look at racism in that way. Racism is, it's as we've seen it, it's a social determinant of health. It's somewhat invisible. And as we've heard today, individuals experience it, but we know that the systems and structures underlying that are all things that we need to dismantle and we need to interrogate. And that's what kind of the Lancet is trying to do with all these various projects. If I just may say one point around children, this is an area that we feel, we focus quite a lot on children in the Lancet with our projects. And one of the reasons has been alluded to today, is that invisibility, is that they are largely ignored in many of the conversations around health. And there's also a very narrow focus. When we think about child health, we think about maternal health and child health under 5, diseases, infections, access to medicines. But, it goes much more beyond that. We know children are exposed to many adverse events and factors that affect their development and their ability to thrive and flourish, and for them to have the best opportunities in their life, in their childhood and adolescence, and then also into their adulthood. And that's why I think this commission is really important, because not only does it take a long-term view, it takes a life course approach view. So, but looking at children at that particular stage, hopefully, if we can focus on the interventions and outcomes, we can stop some of the damage that children and in their later life are exposed to and have to face. And I really hope that this commission can provide that intervention and outcome focus, but will also provide actionable recommendations that are going to be useful for practitioners, for policymakers, and for all of us really to play a part.
Thank you.
Thanks.
If you have any questions, please do send it through to us. We have a couple of questions around timings and timelines. So can you give an idea of the timeline for the research? Maybe I should answer that. So our plan is to work through this over the course of next year. Ideally, in about a year, we would submit the work, and then it goes to Pam, and then I've no idea what happens. But the Commission report is just one aspect of the work, and I will show you our Race and Health website at the end. We have a number of other outputs. We have a podcast, we have a newsletter, webinars. We're hoping to have more creative kinds of work, artistic work, stemming from the engagement work that Sonora mentioned as well. So I see the Commission as just being one aspect of lots of other things that we're trying to do in the space. How will the research findings be implemented so that they will make a difference sooner? Maybe I can pitch that question to all of you. How can we do this so that it has an impact, and it has an impact not in 20 years, but sooner?
I think also from some of our colleagues, other co-commissioners who had been speaking on the video, I'd like to echo that. I think what we need to do is we need to shake up, disrupt a bit how we are working and how we are thinking. I would very much like to see a disruption in the funding system for the whole humanitarian system. But we can't start to make that more fair if we don't have a close look at what exactly is happening. And so I think this will help us on the way to do exactly that. And I also think that there is an appetite for this kind of change, and there are a lot of people who recognize it. So it's a matter of making it really clear, unavoidably clear, and then advocating with the people who make decisions around this, and actually evidence. One thing that donors are frequently doing is they're saying, there was 2005, there was a Paris Declaration that donors should harmonize their reporting requirements. And what we're starting to see is that actually, by and large, they are doing that, but the humanitarian actors are still not able to adequately capture data in children consistently and in a harmonized way. So they end up asking the donors, what do you want us to tell you? And so it's not just a responsibility for donors, but it's a responsibility for not only non-governmental organizations, but also ministries of health for countries to think really carefully about also how what information are we collecting, and what makes most sense to collect. What can we use to inform our programming to improve it? And so, long story short, I think with data we can help to make that argument. And if we show a lack of data, then we can also provide some recommendations for how to change that.
Thank you.
I can think of two things. I think we need to really highlight strongly both the unacceptability of just not dealing with this issue, and the other is really bringing it to the forefront of the design of studies. So I work in nutrition, so I know physical activity and a healthy diet is good for children. The next thing I know is that the people who don't have healthy diets and don't have green space are associated with poverty and lack of education. But why are some people experiencing poverty and lack of education? That's where the racist element of society comes in. Why aren't the interventions getting there rather than just trying to promote physical activity without dealing with the issues that generate inequalities in the first place? So I think the target of interventions needs to change. We need to recognize the role of racism in societal inequalities.
Thank you. I wonder if I can also put that question to all of you, because the implementation of research goes to everyone. I wonder if anyone in the audience has a comment on this. I can come back to you. You can think about it.
Can I just comment on the research aspect? Because I think this is one of the challenges that we as publishers, and coming from a major medical journal like the Lancet, I'm going to admit quite openly we are drawn to these big studies, which sort of aligns with the mindset that big qualitative analyses is going to give the answer. I think in terms of addressing racism, and our anti-racism efforts have got to be in some way to encourage a change in that research ecosystem, to focus on studies that are likely going to give us more meaningful answers, but don't fit the big quantitative RCT or big trial across multi-centre. They're going to be qualitative studies that take context, because let's face it, context is very important. We heard on the film 4 or 5 different perspectives, which are quite, broad and general and apply to us all, but some are very context specific. So we have to somehow encourage that research community, and this goes back to the funders who fund this kind of research, to educate them, to show them that this isn't the only way you're going to get an answer to this problem. And if we haven't got that approach, that we can't do this study, because we're never going to get the answer otherwise. So I think, in a way, I'm not saying how this research is going to be implemented quickly, but I do think that discussion, and I think your work, Delan, and the Commission's work in bringing alive more mixed method approaches, this complex modelling that we've heard a little bit about today, more sort of qualitative analysis, getting the voices of children to be part of the research. I mean, that's not such, it shouldn't be such a progressive thing, but clearly it is. And so we need to just kind of open up our research ecosystem, and I really hope that that's one thing that will come out of this commission from that perspective.
Thank you.
Just to answer your question about implementation. So I'm Ganesh, I'm from the Applied Research Collaboration Northwest London, otherwise known as ARCS, and the whole point of that programme is to try and get research into practice. And I think the key thing is, when you've got the research, is that the NHS wants to use it. So it doesn't matter if you've got a great piece of research, if the NHS doesn't want it at that time, it's not going to get used. So what are the questions that the NHS wants to answer at that moment in time? And then if you've got the right research, then you can work with them to get it implemented. And I think that's the key. And definitely through COVID, although it was horrific, it did open everybody's eyes to the inequalities and the racism out there. And I felt there was a huge movement within NHS management to try and deal with that. And that is still there today. So I think there are some positives, and also National Institute of Health Research are putting a lot of money in to trying to change, in terms of research trials, that they're more diverse than they used to be. So we need all our big funders to start thinking like that.
Yeah, I agree. And I think workforce is a really important issue. So many of the people in the research ecosystem, so many people from minority backgrounds, are not getting those chances, and they're not getting elevated. I know at the Journal, I have to say, there's very few ethnic people at the Lancet. It may not come as a surprise to a lot of you. It's a colonial journal, 200 years old, and sadly some things have been difficult to change. And that's one of the things that we're focusing on. I co-found a group called Grace at the Lancet, which is looking at our workforce, because we believe that in order to improve our efforts in the office, we have to have a workforce that reflects the society we live in. And I think that goes for the same for the research ecosystem. So those funders need to look at, really bringing people from minority and ethnic groups part of the research planning, part of the research programme. I also think a lot of universities belong to this elite sector where research funding is given. That has got to change. I don't know, some of you might read The Times, but every year The Times publish this very snotty elite ranking of where funding goes in terms of universities each year. And it's the same club, it's very exclusive, and sadly, it's very influential. Not helpful at all, because, we want to bring the voices of our southern universities and institutions in the global south to bear. But those sorts of rankings just immediately, funders are just not interested apart from those top 5. So, you know, there's a lot to do here. There really is. So I just wanted to make that point.
Okay, thank you. On the implementation thing, so I teach on a mental health training program at King's College, and I also work in a CAM service in East London. And, you know, there's quite a lot in terms of what training institutes could be doing to teach culturally responsive, adapted approaches, all sorts of things. There's so much available. So it's the barriers in terms of who gets to decide how that's taught and why it's taught. And I mean, it's extraordinary being in an institute like that where you have to fight and fight and fight to actually implement things which are very well recognised. So you can have amazing research, but how do you get to implement it? Because, you know, I'm shoved to the bottom of the pile all the time for talking about anti-racist approaches. So yeah, working against power. So power was hard, you know, it was mentioned briefly, but hardly, you know, what are the systems of power which drive racism? We can talk about the impacts and effects of racism all the time, and we know that really well. There's so much evidence of what the impacts are, but where's the kind of stuff going into what's driving racism? Systems of a power, whiteness, white supremacy, where is that, and how do we recognise and see how that operates in our institutes? Because until we do that, we can't change anything. And that's really threatening for people when power starts to be rearranged. That's when you get people having meltdowns. And yeah, so yeah, we're doing a 2-year program on anti-racism and whiteness. And it's, yeah, I'm going to wait and see what happens, but it's an uphill struggle.
Thank you. And we have a kind of related question. How can we ensure that policy making does not perpetuate colonial perspectives and racism itself? So considering the kind of power structures from the last comment, would any of you like to take that on?
I think sorry, I don't know your name, but I think what you've just said kind of it encompasses that quite well. It's about making. So it's there's two things. The one is you have to be very conscious of the colonial and unequal, just simply the racially unequal distribution of power, and the history behind that. You cannot ignore the history. You have to be aware of it. You have to be aware of that every one of us, whether we like it or not, we're products of that as well. So we will potentially unconsciously reproduce that, and some actors will consciously reproduce it. And some, not necessarily humans, but structures like organizations will most definitely reproduce it. And so you have to know where your starting point is, and then consciously try, basically, that not only in research but in implementation we have to within aid work, both in humanitarian and in development work, there's an effort towards localization is the term. It's a bit of a buzzword, and I don't mean to undermine it, but unfortunately what happens is in the effort to try and give back power and money to groups or people from nations that are affected by crisis or that have limited resources, what we end up doing is giving money to reinforce unfair power distribution that's already existing in that place, which is colonial in its root. So I think first and foremost, it's about awareness, and then everything that we do needs to be reflective in that way, and reflexive and aware, and there needs to be regular sense checking all along the way. It's kind of a continuous process. So it's about reflection and awareness.
Thank you. We have a question about the government Sewell report that said that there's no structural racism in the UK. Recent census analysis in England and Wales showed higher mortality in the white or mixed groups than black and Asian groups. How do you deal with such positions? I can impart answer that. So, I mean, I should say that I looked at the ONS reports just a week ago, so looking at child health. Mortality is high amongst minority groups, amongst Asian groups and black groups, and it's 2 to 3 times higher. I mentioned the infant mortality statistics. It's true for other age groups as well. Generally, across the world, if you look at mortality, morbidity, they are higher amongst groups that are lower in whatever hierarchy exists in that country. And that's the kind of universality of this point. So I haven't seen this particular result, and I don't know that, so I can't point to that exactly. But racism is just one aspect of the causes of mortality and morbidity. It isn't everything. And there are other aspects in certain groups, be they white populations, mixed populations, that will lead to higher morbidity and mortality. And I don't know the specifics of that situation, so I can't answer that entirely.
I mean, that speaks to the whole intersectionality aspect, doesn't it? That we're not looking just at racism, we're looking at gender, caste, religion, class. I mean, these are all discriminatory, prejudiced populations. So if you have 2 or 3 of those characteristics, you're more likely to face adversity.
Yeah. I think, Lou, you'd like to come in as well?
So in one of my conversations with a very, very clever political scientist that works on the Commission called Javier, one of the things he brought up that we really have to be aware of is this thing he called the fabrication of ambiguity. And it's a bit like climate science, that the science, 99%, confident about one fact, but because there are vested interests in challenging that, certain industries, certain interest groups, they come up with alternative facts or ways to make it ambiguous, at least, about what the truth is. And so I think that's one thing we have to be very aware of and clear about when we are sort of trying to deal with racism, that there are different actors, and we just have to be aware of the motivations.
And just on the Sewell report specifically, we did a podcast episode about this in relation to structural racism in the UK and the US, and I'll show you a link at the end to the podcast. We have a sort of, I don't know if it's a more mechanical question, maybe for you, Pam, about the different commissions and how they work together. How do we ensure that the sum is greater than the different parts?
Well, that's a good question. I wonder if it's one of the commissions. The authors of one of the commissions. Is that you?
Yeah, I'm not.
Oh, okay. Well, it's a really good. Sorry, I can use that one. I'm still yours. It's a really good question, and certainly now with so many commissions on the go, the one thing that we've all been very aware of is that we don't want to duplicate efforts. We want to complement each other. And we have to ensure that there is constant dialogue between the commissions. So, for example, the 3 commissions that we've currently ongoing around racism and health, we are keeping in touch. We have certain commissioners who straddle between a couple of the commissions, which is helpful. And we try to meet with the other editors, so 2 of my colleagues are each one working on the other commission, to come together every couple of months and check on progress, what kind of work we're all doing, and if there are ways of leveraging each other or even interacting with each other, then we try and facilitate that opportunity. It is hard because, especially when you have projects that involve very different people that have very different work programs, but we are definitely making more of an effort to ensure that we're just not churning these commissions out, especially related ones in related subjects, without being very specific on the goal and the objective, but also looking at ways of linking with the other projects so that the sum is greater than the apart, because that's what we want. So we are, very much constructively trying to do that more than we probably did in the old days, where we didn't really think about it too much, but now.
So thank you very much. We only have a few minutes left. I wonder if I can just go around all three of you for any final comments. There are a few other questions we haven't answered, so please do come and ask us afterwards. Jonathan, if I can come to you first.
I think I'd just like to emphasize that when I was at the meeting in Sri Lanka, I just saw a tremendous energy and a collective intellectual contribution that is there. So I don't know exactly what the Commission is going to do, but I feel very confident that it's going to come up with some powerful ideas, practical ideas for what can be done. And I think that the complex system modeling, which is trying to identify where are the most effective places for intervention, to me that just seems a really exciting, novel and hopefully, useful way to go.
Yeah, no, and I think to add on to that, actually, there's also, this is a group of people that are working on this in different ways already, obviously, which is why we are able to come together. But at the same time, I don't think it's going to stop when the report is done. I think this is just the beginning. And yeah, so I'm really looking forward to seeing, I'm a bit of a doer, so I'm looking forward to getting on with it and taking it forward also in the longer term.
I think in terms of this particular commission, as I said, I'm very excited about it as a topic. We heard that it's very, it's a very new area of research. There's very little around child health and racism, so it's going to really fill that evidence gap in a way that I think is going to encourage more research, and we're going to get more people from different organisations and institutions interested in this subject and wanting to study it and take it further. I think one of the things that's quite unique about the Lancet Commissions, and this is a challenge to the commissioners, is we have this thing which we describe as the afterlife, and Aisha's sort of alluded to that in her comment just now, in that it's not the report that we're too concerned about, in the sense that that's not where our sort of, let's say, importance is. The important bit is what's going to come after the report. Is we don't want this report to be a scholarly document that everyone pats us on the back and congratulates us, and it'll be on the shelves of academic institutions, and some people may read it, but most people won't. We really want it to have a life. And I think the approach that the Commission's taken so far, interacting with these other external groups like the Children in All Policies group, having children really be at the seat at the table, they're going to be telling us what their concerns are, and we need to listen to them. And they're going to be holding us accountable. And I think that's quite a big challenge, and something that, I just want us to deliver on. And I feel confident that we will. And we've got a great opportunity. Let's take it.
Thank you. So thank you to all three of my guests, Jonathan, Aisha, Pam. And I want to say a few other thank yous. So to Sonora and Lou, who are here, to Meetha Hawke and Abhi Devanagam, two other members of the steering group who couldn't be here in person. Also to Michelle, to Sarah in particular, who organised this day. And to all of you for coming. I just want to mention our Race and Health group, finally. So we have this group that's housed within UCL that anyone can sign up and join. And the idea of this group is to do some of those things, to take the research, to take it outwards to different audiences. The idea of taking this advocacy, disseminating it in different ways, to look at education possibilities, to look at advocacy. And this is open to anyone, so you don't have to be a member of UCL to join this. We have a newsletter that you can sign up to and a podcast, and we have webinars and other activities that we're planning. As was mentioned, the Commission report is just one aspect of this work. We hope that there'll be lots of other things, some creative outputs, some academic outputs that reach different audiences in different ways. So if anyone is keen to join this process, please do get in touch with me. Thank you very much. Thank you to all of you for coming.